Okay, hello everyone and welcome to BrainMap. This seminar series is co-sponsored by the P41-funded Center for Mesoscale Mapping housed in the Martinos Center. It's my great pleasure to introduce our speaker today, Dr. Marion Smith. Dr. Smith is a full professor of applied physiological neuroimaging, the chief of neuroradiology, and co-chair of neuroradiology fellowship program at Erasmus MC University Medical Center, Rotterdam. Dr. Smith uses physiological imaging techniques to visualize the brain's function and microarchitecture. She also studies the pathophysiological and regenerative processes in a variety of neurological diseases. Her current focus is neuro-oncology, but she has also worked extensively in the field of dementia and brain trauma. She is dedicated to breaking down the boundaries between research arena and the clinical practice and vice versa. And she also did a huge work reflected in both her numerous teaching activities, plenty of papers, of course, and leadership positions, including the European MRI community. I would just like to remind the audience to please address any question you have using the Q&A box or raise your hand. Dr. Smith, thank you so much for coming here today. The virtual stage is all yours.
Thank you so much for the invitation. I'm really honored also by this introduction. And as you said, I'm a clinician, I'm a neuroradiologist. So I'd like to take you through some of the challenges that we encounter in neuro-oncology from an imaging perspective, but also some opportunities. And of course, I know you're all, working on brain imaging. So I'm also hoping to pick your brain and to maybe inspire you to help me solve these challenges with all of the knowledge that you all have. I'm also aware of the fact, these are my disclosures, none of those pose a financial conflict of interest to the content of my talk at the moment. And I'm also aware of the fact that not all of you are familiar or working with brain tumors. So I'd just like to give you a very brief introduction of primary brain tumors and in particular glioma, which I'll be talking about most in my talk. So this is the fact sheet about brain tumors in the US. This is from 2012, so it's a bit old, but it's still mostly accurate. So what you can see here is that there's quite a lot of primary brain tumor types, but there's also a lot of secondary brain tumors called brain metastases. And these make up the vast majority of the brain tumors that we encounter, especially of the malignant ones. But I'm going to talk about the more rare cases and particularly the malignant tumors. And as you can see, thankfully, that is the minority of primary brain tumors that we see. And these are the numbers of brain and other central nervous cancer. And as you can see, it's not the most common one, number 16. But as you can see also that if you look at the estimated number of new cases versus the number of deaths, you can see that this is a disease that is rare, but has a very high mortality. And it also has a very high morbidity. So the most common adult, I'm only going to talk about adult type glial tumors, is glioma. And these are basically based on their cell lines differentiate between astrocytoma and oligodendroglioma. Now, this is going to become a little bit confusing throughout the talk because we've gone through various stages of classifying these tumors based on cell lines and now more or less mostly on genetics. So this terminology is now a little bit confusing, but I'll try to keep it a little bit, clear. And basically astrocytoma and oligodendrocytoma refer to the cell lines that they derive from. So as most of you probably know, these are the cells that make up the white matter. So the supporting sort of cells within the brain in the white matter, astrocytes and oligodendrocytes. So if you're looking at the types of tumors, then the astrocytoma tumors can be graded based on how different they are from the original cell. So the more anaplastic or dysplastic they become, the higher the grade. And specifically a specific type of astrocytoma is glioblastoma. And again, this is where things are a little bit confusing. This used to be also a part of astrocytoma, but is now considered a separate entity. And I'll come back to that in a minute. Oligodendroglioma only knows grades 2 and 3, and again, the higher the grade, the more dysplastic the tumor is, so the more removed it is from the original cell, if you look at it on histopathology. So this typing and grading is done according to the World Health Organization, the WHO classification, and is known to be prognostic and predictive. So it gives you information on how the patient does with or without even treatment. And it's associated with imaging features. So a lot of these tumors we can actually, to a certain extent, type and grade with imaging. It determines the treatment management. And until, like I said, 2016, when there was really a revolution in the classification, this was solely based on histopathological features. And now we're using a lot of molecular features. Hence, we're still in a transition phase, so there's a lot of confusing terminology here. So when we think about imaging in neuro-oncology, there's basically three pillars that we need to consider. So there's the clinical trials, where the imaging is extremely basic, and all we're basically interested in is, well, tumor size or the size of the abnormalities is maybe better description. Then there's the imaging that's done in a brain tumor center, so a center where we do a bit more, where there's neurosurgery, where there's treatment of brain tumor patients. And then, of course, there's the lab where development is done of, well, tumor biology mapping techniques, such as these listed here. And I'll go into detail in some of these throughout the course of my talk to indicate where we use these techniques and where I'm working on it, and of course, where I think there's use for them as well. Well, let's start with the clinical trials. And this is, I mean, the basic of the basic. And this is something that we don't always realize, that we're still working with the really, really basic imaging in these trials. But our support in clinical trials is really, really important, because as you can read here in this quote from 2014, which unfortunately is still true, there have been a lot of trials, but a lot of them have failed. And that means that there is a 25-to-1 failure ratio in getting new brain tumor treatments over the past 2.5 decades now. So we're desperately seeking new treatments for brain tumors. The outcome is still very poor. And of course, as imagers, we can offer support in these trials. So what do we need to do? Well, we first need to be able to select patients for trial inclusion. And this is not trivial, because a lot of these patients are entered into a trial upon, after their initial treatment has failed. So we need to select these patients that are truly progressive, and that is not trivial, and I'll show you that in a minute. We also, of course, need to determine the mostly secondary endpoints, so the progression-free survival, but sometimes even the tumor size is a primary endpoint. Most commonly, overall survival is a primary endpoint. And what complicates clinical trials in neuro-oncology and in oncology in general is that traditionally there was no involvement of radiology. So the imaging was performed according to local protocols. Sites were basically selected based on their oncological expertise and on how many patients they could recruit. There was generally, therefore, no advanced imaging, a wide variety of scanning equipment and implementation, and no quality assurance. And this field is shifting, but it's slowly happening. So that means that still there's a lot of variation in how we select patients for trials, and also how we assess the outcome in these patients. And that means that we are basically very limited diagnostic accuracy at the moment, compared to, of course, what we can do and what we do in our clinical practice in a brain tumor center, or even in our research setting. So again, it's good to keep in mind that we are very, very basic here. So like I said, what we use is T2 weighted imaging and post-contrast T1 weighted imaging. That's basically all that response assessment is based upon. And these are described in the so-called RANO criteria. These are high-grade tumors. There's also one for low-grade tumors. And these basically indicate that you have to do, sorry, there's a typo here, a bidimensional measurement of the solid enhancement. Well, how are we going to measure this tumor? Well, most people would probably assume that it needs to be, the enhancing portion. But if you think, well, solid enhancement, then maybe only this portion needs to be measured. So you can imagine that this is not a very clear distinction, and that there's a lot of variability between raters. And of course, it's not an accurate reflection of tumor size anyway. So we're all sort of thinking this is probably not the best way to go. So a lot of work has been done in assessing this response automatically by segmenting the tumors automatically. And this is work by the Heidelberg group, by Philip Kickengerede, where they show these are the two lines of the progression free survival, so the proportion of patients that are without progression. And you can see that for a radiological assessment according to RANO and for their automatic response assessment, these lines overlap. So we basically get a very, very good agreement between these two assessments. What they also showed, which I'm not showing you here, is actually that their automated assessment had a better correlation with the outcome in these patients. So that means that this sort of 3D assessment, this automated segmentation probably works better. And of course, this is something that is being investigated, but is still not happening. So again, all of these clinical trials are being done now manually, drawing these lines and with a lot of variability. So that means that, of course, we have a lot of problems with measuring outcome after treatment, and that's not just it. The other problem is the abnormalities that we see, or the effects that we see of treatment that are not related to the tumor activity. And these are two types of challenges. The one is, on the one hand, there's a pseudo response, so where it looks like there is a response to the treatment, but in actual fact, all what we're seeing is a change in the abnormalities on imaging without an actual anti-tumor effect. I'll show you an example in a minute. And the reverse is the pseudo progression, where we see an increase in abnormalities on radiological imaging without actually a tumor progression. So this is called pseudo progression. So the pseudo response is typically related to anti-angiogenic agents. So these normalize the vasculature, of course, and this makes the tumor appear to disappear, where we also see a decrease in T2 abnormalities, but again, this is an unspecific finding. And the pseudo progression is something that's related to radiation therapy, chemotherapy, and also now immunotherapies, where we see enhancement and edema that is really indistinguishable from tumor. And this really particularly is a big problem for selecting patients for trials, because, like I said, we're including patients in trials at the time that they are progressive on their normal treatment. So that's the radiation or the chemotherapy. So they don't respond or seem to respond to their initial treatment, and that's when they enter a clinical trial. Of course, if this means that the patient is pseudo-progressive, these changes will disappear, or these abnormalities will disappear without an actual effect of the trial treatment. So that really obscures, of course, your effect of your trial. That means, so this is a known effect, that means that now patients are being excluded from inclusion in trials if they are progressive within 6 months after radiation or chemotherapy. And of course, that then misses the window where the patients were truly progressive. So because you exclude them for 6 months, so they've already progressed beyond those 6 months. Whereas, of course, the earlier you treat, you hope that you're more effective in your treatment. So this is a real problem. And if we can do something with our imaging to improve this, this will also help us to get better patients into the trials and therefore have better outcomes in our trials. So this is an example of the pseudo response. So this is in a patient that was originally included in the first trials for bevacizumab, an anti-angiogenic agent, also called Avastin. And you can see the very dramatic decrease in enhancement here. So here the enhancing portions of the tumor, they've mostly disappeared after treatment. So of course, this was considered at that time a fantastic effect and a response, and this led to an accelerated approval by the FDA at the time. But only when we started looking at the primary endpoints, so the overall survival, you can see in 2 big trials that this did not improve, bevacizumab did in fact not improve overall survival. So even though progression-free survival was longer, the imaging abnormalities, were gone, the overall survival was not actually better. And that's based on our still current clinical trial endpoints or outcomes with RANO, where we measure the enhancing portion of the tumor. So, can we even assess response with imaging? Well, this is, of course, where we need to, at some point, move towards the techniques that we have available in our brain tumor center. And we looked at this in a study. This is work from now a postgraduate, a graduated PhD student. She looked at the first response after treatment using just simple diffusion weighted imaging, where we looked at the patients that received anti-angiogenic treatment versus conventional chemotherapy. And you can see that in orange, the patients that received bevacizumab actually had a high proportion of diffusion restriction, whereas that was not really visible in the chemotherapy group. Well, we know, so there's diffusion restriction with bevacizumab. Well, we know that was already described in the early days in 2010. But the question is there a clinical relevance to this? So to assess this, we looked at the survival curves. So you're looking here at bevacizumab treatment. This is the overall survival in days. And you can see in blue the line of patients that had more than a 25% decrease of their minimal ADC, versus those that didn't. And you can see that those that didn't, here in green, had a worse survival than those in blue. So it looks like if there is a decrease, and we didn't see that effect in the chemotherapy group. So it looks like if there is a reduction in ADC, a significant reduction in ADC directly after the first dose of bevacizumab, this does seem to indicate a treatment effect in the sense that there is an improved survival. So that could be one of the ways in which we can include a new imaging marker into our trials to assess treatment response. But again, that is not done commonly yet. Let's move to pseudoprogression. So this is two examples of two patients after chemoradiation. So that is the standard of care in patients with a high-grade glioma. You can see this patient had a little bit of enhancement still after the treatment. This patient's resection cavity, no other abnormalities here. 3 months later, we can see that this area of enhancement has massively increased. And here we can see a new focus of enhancement. We cannot tell whether this is tumor progression or pseudoprogression. We can only say there's an increase of abnormalities, and we don't know what it is based on conventional imaging. And again, conventional imaging is all we use at the moment in clinical trials. And this is something that I see about 10 times a week in our brain tumor board meetings. I get the question, is this tumor progression or is this pseudoprogression? Of course, remember, for the patient, this is a huge difference. Tumor progression means the treatment is not working. They will probably, die very soon. Whereas in pseudoprogression, the treatment has actually been effective, and you don't need to do anything. And, these abnormalities will disappear by themselves, and these patients have a much better outcome. So one of the ways to deal with this is to look at perfusion, the idea being that in tumor progression, of course, there's tumor cells, there's vascularization, so therefore high perfusion, whereas in pseudoprogression, this is more of a reactive, sort of almost stroke-like reaction that you see in the brain parenchyma as a result of the damage that's done by the radiation and the chemotherapy, and therefore low perfusion. And in this case, we can see that the perfusion is very low. We calculate ratios. We don't use absolute values, but we calculate a ratio compared to the contralateral white matter. And this was a case of pseudoprogression, whereas the other patient had a region of this lesion had high perfusion, and this was in fact tumor progression. So these are, of course, my best cases where it's all very clear. But the accuracy is not 100%. And this is an overview of meta-analyses that are done on this particular research question, distinguishing tumor recurrence or progression from treatment-related abnormalities. You can see there's a lot of studies done with a lot of techniques. So what I just showed you was DSC, dynamic susceptibility contrast enhanced imaging, but also dynamic contrast enhancer, the T1 weighted technique has been assessed, as well as ASL, but the majority of the studies has been done with DSC. And you can see that the areas under the curve are, pretty good, around 0.9, with also, relatively good sensitivities and specificities. Unfortunately, this is not what we see in clinical practice. In my experience, and in not only mine, but in many other people's experience, the actual accuracy is a lot lower. And I think we're looking at very optimistic and inflated numbers here, because almost all of these studies have used their own population to determine a threshold that is optimal for then getting, the highest area under the curve and sensitivity and specificity. And these thresholds have not been externally validated in either of these studies. So of course, if you then sort of work with either of these thresholds, you will get a much lower accuracy. So this is a real problem that we're now trying to solve. I don't have a slide on this, but we're doing a very large study in the Netherlands, with all centers in the Netherlands participating, to really look at what is the true value and true accuracy of perfusion imaging in these patients. So there's more issues with perfusion MRI than just the evidence or the lack of evidence that we have. So especially DSC is not a quantitative technique. So we use these ratios and we need to find a hotspot. So of course, this very much depends on the site and the user, as well as, of course, the analysis that is being done, the algorithm, the post-processing tools. There's such a multitude of tools available. And especially in our clinical practice, most people don't actually, they use the tools that are available to them and don't really know what the particular pitfalls are. And this is a particular problem when there's blood-brain barrier disruption, which is needs to be corrected for in specifically in DSC perfusion. And on top of all of that, there is a lack of consensus in the community still on how we need to assess and how we need to interpret our findings. This is a very, very good paper by Laura Bell and Chad Cross, where they looked at basically using a DRO, digital reference object, the impact that imaging protocol IP and the post-processing method has on the interclass correlations that you see here. For an intact blood-brain barrier and disrupted blood-brain barrier. And this is, of course, what we're mostly looking at. We're mostly looking at enhancing lesions. And you can see things are pretty good if the post-processing methods are maintained stable. So everybody, basically, this is where everybody sent their images and they did the analysis with their post-processing tools. But this goes very dramatically wrong if the sites use their own imaging protocol and their own post-processing tools that really, well, doesn't give you very, very concordant results between sites and raters. And this is something that is not really known to many people and also just not reported in many, many studies, so that we don't really know what the true value, again, is of what is all reported in the literature on perfusion imaging. This is one of our own studies. This is where we use data from multiple sites within the EORTC. So the EORTC is the European Organization for Research and Treatment of Cancer. And this is where all of the clinical trials basically at a European level are being coordinated. And what we did was we had 3 reviewers in red, in blue, and in green. Each did 2 assessments of 17 patients, and they looked at the RCBV, and we categorized a little bit by sort of low, slightly increased, moderately increased, and very much increased. And you can see that there are a lot of patients where there's actually a very good concordance. But here we can see that these patients are basically all over the place. Also, not only between raters, also within the same rater. And that means that our interclass coefficient is actually quite high because the variability between raters is in fact higher than that, lower than that of the within rater. And that is also reflected here in a very low repeatability. So we're not really there yet on using multiple raters to use multi-site data to look at, to use perfusion imaging in a clinical trial. What we did see, however, is that if you looked at, I don't have that here, but if you looked at how often two raters were in fact in agreement with each other, then that was actually pretty good. So the idea is, if you want to do this, do centralized review with two raters so that you have some kind of concordance across these studies. So, I mean, I've done all of the negatives, but I think perfusion MRI is still a very powerful tool for clinical trials and for our clinical practice, because there is a clear biological correlate. Like I said, the increase in vascularization is a known fact. This has been assessed with histopathological targeted biopsies, when we know that where there is high perfusion on our imaging, there is also a high vascularization in the tumor, and that is known to correlate. This is in fact a criterion for the tumor grade and for the presence of high-grade tumor. So the biological correlate is there. So we are stuck with the technical problems here. So we need an improvement of our acquisition techniques. And of course, these are being developed, like with combined, for DSC, combined spin echo and gradient echo techniques. Post-processing techniques are of course being developed as well. And of course, we need to get some agreement on what we think is important. I think a lot can be resolved if we remove the user dependency using semi-automated or automated analyses. And of course, we need to standardize. We as a community of radiologists, of imaging experts in general, need to standardize how we acquire and post-process our perfusion imaging data for this particular indication, as well as, of course, for other indications. Well, big steps have been made. Last year, consensus recommendations for DSC MRI have been published based on not only expert opinions, but on also simulations where various protocols were tested, and there's clear recommendations now. All we need now is for people to follow them, which is another big step. But that's why I keep saying this everywhere where I get the opportunity. So just to show you the power. So I've done all of the negatives, but also the power of perfusion MRI. And this leads me to my next section on how we use imaging in neuro-oncological practice. So this is T2-weighted imaging, post-contrast imaging, and perfusion imaging of a 57-year-old female. She had a progressive neurological deficit and she had seizures. That was the reason for the scan. And we can see that there's multiple abnormalities on T2-weighted imaging. They don't even look, if you think about that first patient that I showed you with that very big tumor that we tried to measure, this looks, not so aggressive and not so angry and big. There's no enhancement, but we do see that there's an area with high perfusion. So that makes us think that this is a potentially aggressive tumor. Maybe not all of this, but this area looks like that might be higher grade tumor and therefore more aggressive. This tumor was biopsied. This came back as a grade 2 tumor, so actually consistent with what we see here, no enhancement, not too big. But the tumor was then, and I'll come back to that in a second, run through, or the tissue was run through next generation sequencing. And these are mutations that we typically see with a very, very aggressive tumor. So even though the grade is low, so basically we caught this early, we have a very aggressive genetic profile, which is consistent already with this imaging finding of high perfusion. And this is in fact what we would now consider glioblastoma, and therefore is treated as such, even though the grade is quite low and it all looks fairly innocent. So again, our perfusion imaging can help us here to detect that area of aggressiveness. And probably if we had biopsied this particular area, we probably would have found a higher grade as well. So that brings me to the classification. So the WHO classification, like I said, was a bit of a revolution in 2016 when for the first time molecular parameters were included in the classification. So the genetics of the tumor are added to histology. And like I said, we now have a bit of a transition phase where both histology and genetics are being used. But of course, for us, there is a huge opportunity here to also develop techniques to diagnose the glioma genotypes. So this is now the published in September of this year, 2021 classification. This is the summary paper, and the full classification can also be found since a few weeks online as a book before it's going to be printed or available in print next year. So what we can see here, so let me point towards the terms that I've already used. So we have our oligodendroglioma, astrocytoma, and the glioblastoma. Like I said, basically glioblastoma is also derived from astrocytic cells, but is now considered a completely separate entity based on the molecular status. Here we see the grades before I go to the genetic status, so grade 2, 3, and 4. So we still have those in place. So there's still histology if we want to use it. But the main thing is now the genetics. So there's two mutations that are really important. There's the Idh mutation. So this is Idh mutated tumors, and there's the Idh wild type tumors. So this is basically the tumors that don't have this Idh mutation. They do have other mutations. So there's also other tumors that are Idh wild type that I'm not listing here. They're not glioblastoma, but with these specific mutations, and I won't go into detail because I know many of you don't work in glioma, but important to know that all of these tumors are now based on this mutational status, irrespective of the grade. They're called glioblastoma and treated as such. If we're looking at the Idh mutated tumors, we have another set of mutations to look at. There's the co-deletion of 1p and 19q, and this basically defines the oligodendroglioma type. We already knew this. This was a hallmark feature from oligodendroglioma when we still used the histopathological typing. But now this has now become a defining molecular status. So even if it doesn't look like an oligodendroglioma on histopathology, if this mutation is present, it will be an oligodendroglioma with grades 2 and 3. And if there is an Idh mutation and 1p19q is not co-deleted, so it is intact, but there are other mutations there, then we're looking at astrocytoma. The big change for the people that do work in glioma, what used to be a grade 4 Idh mutated tumor used to be an Idh mutated glioblastoma. That has now changed to glioblastomas only for the Idh wild type tumors, and the grade 4 Idh mutated tumors are now called grade 4 astrocytoma. Grading, this is the final thing to say about this, is not only done now based on histopathology, but also based on genetics or on histopathology as well. So again, we have some more genetic features included in this classification. And of course, these are all things that make it probably easier for us to diagnose these tumors. And I'll show you why. Because why did we even move from this histopathological classification to this molecular classification? Well, because we can actually define these tumors much more accurately here based on overall survival. But of course, that is probably also reflected in their imaging. If we weren't able to separate these tumors very, very well based on histopathology, so here you can see what the overall survival is for oligodendroglioma in yellow, astrocytoma in red, and glioblastoma. So we can separate them a little bit, and we could separate them a little bit on imaging, but it's not great. This clearly is a lot better. So this biologically, they're much better separated. And that is probably reflected in the imaging as well. So our molecular classification probably helps us to also diagnose with much higher accuracy. But this is why it's important to know this. And again, you can see oligodendroglioma tumors, they do pretty well. You see survival of, at least 15 years for about half of these patients. But glioblastoma, you can see how dismal their prognosis is, where after a year and a bit, more than half of the patients have already deceased. So that brings me, of course, to linking that genetic profile to imaging, and that is called imaging genomics or radiogenomics. And the premise, of course, is that there is a correlation between the medical imaging features and the underlying biological information. And that is what we work with anyway in radiology. So most of the times this is true, although of course, maybe not perfect. And there is a review paper about this from a few years ago, where we already looked at that at the WHO classification 2016. But there's earlier work already from 2008 where people used MRI phenotypes, and this was just manually assessed. So was there necrosis, was there enhancement, what did the tumor look like, and correlated that with specific expression of genes. And we could already separate some of these genes or identify these and correlate them with these specific phenotypes. So that's, the early days, based on what I'd like to call manual radiomics. So people really just doing this manually using the Vasari criteria. So these are some very well-defined visual features that we can score with a high inter-rater agreement on glioblastoma scans. And a lot of scans have been rated like this and added to the TCIA, the Cancer Imaging Archive, with these features. So this is really the first steps towards these imaging genomics that have been taken, with a lot of work from people who annotated these scans manually. Of course, now we like to do everything automatically. I'm sure you're all familiar with radiomics, so I'm not going to go into detail here. But what I would like to focus on is the segmentation step. And this is work that I'd like to show by my PhD student, Karen van Garderen. This is not a solved problem. There was just last week a challenge at RSNA together with ASMR and MICHI on segmenting brain tumors again. And we want to use this in clinical practice. We want to automatically outline these tumors and use them so that we don't have to do this stupid pseudo drawing of 2 diameters, knowing that, of course, if we look at a tumor like this, so all of the hyperintensity here on this flare image is probably tumor. So yeah, obviously just measuring this with just diameters doesn't make any sense. So you want to have a volume. So we used an algorithm that is available again from the Heidelberg group. We implemented this in our own pipeline called Idh, and we used a reference data set to assess whether the segmentations were acceptable or unacceptable. And you can see it's not perfect. So about 2/3 were acceptable. But it does mean that, we have now a pipeline in place where we will ask the radiologist, do you think this scan is the segmentation acceptable? If yes, then it continues to be used. If not, then we can't use it, but then at least we've tried. And what we see is that in a lot of cases, the follow-up patients, most scans will be acceptable in the same patient, and the algorithm will fail in certain patients, even in their follow-up. And actually, if we look at the first 3 months of usage, where we had 162 scans annotated and segmented and then annotated, we can see actually that there's quite a good score for acceptability. So again, it's not perfect, but these are the first steps we can take to use these advanced techniques in our clinical practice, and hopefully also in our clinical trials, and get much better outcome measures. But you can see how slow this is and how cumbersome this is. So of course, the big question is, can we now use MRI to diagnose a tumor and eventually maybe replace tissue diagnosis? What happens now, of course, a tumor does get operated upon, so you get tissue to make the diagnosis, but sometimes the patient is too frail for surgery, or the tumor is in such a location that you can't do a good resection, and then just only a biopsy is done, which is still a procedure. It's invasive, patient needs to be admitted. It's scary. I would be very scared. How good would it be if we could just use MRI instead? Well, let's see whether we can do that. So just some of the imaging features that we're looking at and some of the results that we have from our radiogenomics pipelines. So these are a typical oligodendroglioma, so this 1p19q codeleted tumor versus astrocytoma, so Idh mutated 1p19q intact. And you can see the difference. This is a much more homogeneous tumor. You can outline it. You can really see a very nice sharp border, whereas this tumor is much more heterogeneous. It's a bit of a vague border. It's very commonly located in the frontal lobe. So we can already, based on our visual assessment, give some impression of this tumor diagnosis. And I'll come back to that in a minute, how good we are. Also, what we see is that these tumors, these 1p19q codeleted tumors, tend to have a somewhat higher perfusion. They have their own vascularization compared to the non-codeleted tumors. And of course, if you want to quantify the heterogeneity, we can use texture analysis, and you can see for the codeleted tumors versus the intact tumors that there is a nice separation on the T2 weighted images, which was much better in accuracy compared to the visual assessment. So can we do all of this automatically? So this is work from my two previous PhD students. They now have obtained their PhDs, where they looked just at, again, just T1 weighted and T2 weighted imaging, so nothing fancy, at the accuracy of predicting the 1p19q codeletion status in these tumors. And we also asked neurosurgeons as well as neuroradiologists to do an assessment, as well as the algorithm. So the algorithm had an accuracy of about 70%. The radiologists averaged about 63%, and we could see that the neurosurgeons averaged about 49%. So there are multiple very good messages here, which I won't go into detail as a neuroradiologist, but of course, the algorithm already wins. It's not great, but it's still very good. And important here, I want to highlight, is that we use an entirely independent validation cohort to obtain these results. And we have improved since then, so I'll show you that in a minute. Let's go to the astrocytoma. So here, the 1p19q Idh mutant tumors, astrocytomas, the hallmark feature that we don't always see, and in fact often not see, but if we do see it, is very, very, very specific, is the so-called T2 flare mismatch sign. What you can see here in this tumor is that we have this nice, again, sharply defined tumor, homogeneous hyperintensity on T2 weighted imaging, and after on the flare imaging, we can see that there is still a hyperintense rim, but the rest of the lesion actually loses that hyperintensity. So this is called the T2 flare mismatch. We don't see that here in this oligodendroglioma, again, 1p19q codeleted tumor. Again, you can see this heterogeneity that we saw before. It's much less well defined. We can see there's a little cyst, which of course loses its signal on the T2 flare imaging, but the rest of the tumor, the actual solid component, doesn't lose its hyperintensity between T2 weighted and flare imaging. So there's no mismatch sign here. So this has a very high specificity, doesn't have a very high sensitivity, but if we see it, it is very specific. This also goes for the more aggressive tumors. So we can see here the feature of this grade 4 astrocytoma. Again, we have a T2 flare mismatch sign, and we can also see that there is some enhancement. And what is very different between these tumors and glioblastoma, so the Idh wild type tumors, is that we have a relatively larger portion of non-enhancing versus enhancing tumor. So that helps us differentiate this IDH mutant, what we used to call glioblastoma, but now call grade 4 astrocytoma, from the IDH wild type glioblastoma. It's not always that easy. This was actually mislabeled by our algorithm, even though we have a relatively small proportion of enhancement in this non-enhancing larger portion, where we have the pathology actually shows us an IDH wild type tumor versus an IDH mutant, which was predicted by the algorithm. IDH, and this is very important, but I don't have any experience with it, so IDH is related to the accumulation of 2-hydroxyglutarate, 2-HG. And this is considered an oncometabolite. And basically, IDH is important in the citric acid cycle. And if there is a mutation, instead of converting isocitrate to alpha ketoglutarate, we get an accumulation of 2-hydroxyglutarate. And this is either cytoplasmic or mitochondrial for the different mutations. And this can be detected with spectroscopy. But like I said, I do not have any personal experience with this. We don't use this, but the results in the literature are very, very good for this. And this is, of course, to my mind, a real biomarker where we can measure something that is clearly related directly to the mutation, and that can be a response marker as well as a progression marker. So the IDH wild type tumor, so the glioblastoma, what we used to call primary glioblastoma, they are unfortunately the most common astrocytic, or even the most common glioma in adults. So this makes up about 50%. And these are the imaging features. So you can see a much more aggressively enhancing tumor, central necrosis, a bit of hemorrhage, blood vessels, and high perfusion. And these are the tumors that do very, very poorly. But as you saw, there are also other ways of presenting where we do have this maybe high perfusion, but not this very typical case. Again, this was a misdiagnosis. I'm just going to skip this for now because I have a lot more to say. So this is the most recent version of our algorithm. The code is all available open source for you who want to look at this. It's on archive at the moment. It hasn't been accepted yet for publication. And this is where basically the algorithm segments the tumor as well as predicts the grade and the mutational type. And here we get much better results. Again, this is in an external validation set, so previously unseen by the algorithm, different institutions, different patients, obviously, different scanners. And we now reach areas under the curve that approximate 90% for predicting the IDH mutation status as well as the 1p19q codeletion status. So I think we're getting closer and closer to making it a reality that we can predict the type and the grade based on imaging only. And again, this is only based on conventional imaging as opposed to the more advanced techniques that we are, of course, now including in our algorithms as well. So the question is, does it really matter? Like I said, most of these patients do get surgery, but I do want to highlight that this, again, is a shifting field. So what we see here is a patient with a tumor with a large enhancing portion, but also a very large non-enhancing portion, and a big cystic lesion as well. It's not so much central necrosis, so you could really wonder what type this tumor this is. This was treated like it would be a glioblastoma, which means that the resection would only be the enhancing portion. So that was beautifully resected. We can see that the enhancement is mostly gone. But then the histopathology came back and the genetic status came back, and we now know that this is an IDH mutant tumor. That means it should have been treated and resected as such. That means this is all considered tumor as well. And therefore, instead of thinking that we had a gross total resection, we actually didn't have a gross total resection at all. There is a very large residual tumor. So you either would have to then go back and resect if you think that's possible. If it's not possible, then maybe this patient shouldn't have had a surgery at all, because it's basically not helpful to resect only part of the tumor. An important other feature that is very important is that we can also, of course, follow up tumors along their time course. We know that the genetics in these tumors change, but of course we can't just keep taking tissue samples at every stage, whereas we do a scan every 3 to 6 months, depending on what kind of tumor it is. This longitudinal heterogeneity or longitudinal changes is work that the GLASS consortium looks at, the Glioma Longitudinal Analysis Consortium, driven by the more basic scientists, so the people who look at the molecular biology and the pathology. But of course, imaging is hugely important here as well. This is one of the first results from this study. And we now have iGLASS, the imaging glass, where we are linking the imaging with these changes that we see in histopathology or in tissue as well. That's to come. I don't have results on this yet. The other thing why it's also important to be able to look at genetics with imaging is spatial heterogeneity. Again, there are differences within the tumor. We know that. And of course, if you take the whole tumor out, you will get some idea of the spatial heterogeneity. But if you do only a tissue sample, like is done quite a bit at the time, it's very good to know where specific mutations in the tumor are so that you can target this. Well, of course, and this is something that we can't just look at with our simple diffusion or perfusion imaging. And here we really want to dig down into the tumor biology. And I'm really running out of time, so I'm going to be brief on this. But this is work that is currently being done by Esther Barnett, who is now an assistant professor in my lab, together with 2 PhD students who really look at digging down into this tumor biology. These are CEST images. We're also doing oxygen extraction, oxygenation mapping, and in-depth vascularization mapping of these tumors. And what we're trying to do is highlight areas or find areas pre-operatively that we're then asking the surgeon to specifically target. And then this is for the CEST study, where we do proteomics analyses to really correlate the tissue samples and the protein contents with our signal on the CEST imaging. And this is an example where we do the same, but then for, in this case, just CBV and oxygen extraction fraction, where we use a specific histopathological staining, in this case for the CD31, which gives us an indication of the blood vessels. So we can see in this area with a very high CBV that we have all of these red dots are blood vessels, versus this tissue sample, which was taken in a very low perfusion area where we don't have as much of these red dots. And here we see the oxygen extraction fraction again for the first tissue sample. This is where we have HIF alpha staining, where a blue area gives you a much more anoxic tissue. So that's consistent with this area. So this is how we try to really understand how our imaging and validate our imaging findings. I'm going to spend a few more minutes, but I'm not going to reach the end, but a few more minutes on the last challenge, which I think is really, really important. And that is for us as radiologists, but of course, this is where all imaging experts can help, is to do no harm to our patients. And in this particular case, I'm talking about gadolinium, where of course we all know that we're now having concerns about the retention of gadolinium-based gadolinium within tissues in the brain, but of course also on other tissues. And we should really, again, be aware that we should limit the use of gadolinium-based contrast agents to circumstances where we really just need them. And of course, it's just become standard of care. It's practice that we always give contrast in the follow-up of our brain tumor patients. And I'm not going to say that all of our contrast agents should be, thrown out and we should never use contrast again. But I think we have to rethink our almost dogmatic approach because, of course, contrast agents were introduced at the time that our imaging wasn't as powerful as it was now, not just in all of the new techniques, but also in our conventional techniques. If you compare our current conventional structural imaging with that of 20 years ago or 30 years ago when we started using contrast agents, there's such a huge difference, and we can see so much more now that we need to really, really be having a rethink. I think this is not my work, this is from the literature. CEST, of course, is one of the contenders for also helping us to reduce contrast agent. This is a really, I think, very powerful example. This is actually brain metastasis, which was irradiated. This is a patient that responded, where you can see that the ring enhancement doesn't really change after 1 week, but you can see that the CEST signal really changes. Whereas this is a non-responder, where we can see that, again, there is after a week, of course, you can see that there is no real change, but you can see that the CEST signal remains high. And after a month, we can see that this was the response. There was a low signal, much smaller lesion, whereas this lesion did not respond. So CEST really, really helps us. I think I'm going to have to skip, in the interest of time, this section. I'm going to see whether I can go to the last slide for my conclusion. Yes. So I think with what we call precision medicine now, we really need to be aware of all of these various phenotypes, to be able to diagnose them, such that we can detect disease and changes in disease early. This is now what we need for precision medicine. Not every patient with a tumor gets treated the same. We need to monitor response. We have a lot of problems with newer treatments, and we want to be able to be powerful in our trials to find treatment effects, because we really need those new treatments as well. And this is where we can help. And somehow we need to get these advanced diagnostic tools that we're developing in the MRI lab, that you guys are all developing, into our clinical practice, but also in clinical trials. And for this, we have a huge effort for a consensus for powerful tools that are not so user dependent. So I've shown you some challenges for response assessment with MRI due to the therapeutic regimes, and that's just going to get worse, where conventional MRI is practically meaningless. We don't really have, at the moment, a very reliable imaging biomarker available. We still need to look at the role of perfusion imaging, but I think there is a bright future for perfusion as well as other imaging techniques, but that really means that we all need to be involved. I just want to bring your attention to the Mri Together Workshop, which is free, and which is organized for all over the world, for everybody all over the world. So if you haven't heard of it, it's going to be next week, 13th of December to the 16th. I would like to thank you very much for your attention. And of course, this was not my own work. This was the work of a group and my collaborators, as you can see, in increasing age, the seniority of the people that I work with. Thank you very much. And I do apologize for going over time.
Thank you so much, Dr. Smith, for this great talk. And we now move to the Q&A phase. I'd just like to remind the audience to please address any question you have with either the Q&A box, the chat, or just raise your virtual hand. And while people are typing, I'll use the opportunity to ask a question. You've commented about the reproducibility of using different post-processing methods in different sites and the effects of different observers. Can you also comment about the use of different acquisition schedules and different vendors? Do you see a contamination or huge differences due to those different sources?
Yeah, absolutely. I think that is, again, our problem. And I mean, this is a little bit the work with the DRO, of course, showed that as well. We see this in our clinical practice, of course, as well. It's difficult for brain tumor patients to, in this group, and especially for contrast enhanced scans to really look at this reproducibility, because you then have to, give contrast multiple times in a patient on multiple scanners. But it is a huge problem. And I think this is also where we have to have the vendors at some point on board to help us to not have a different implementation of every sequence and call it the same, but actually to make sure that we have implementations that are the same. And they are starting to realize that. I mean, in my ideal world, a scanner comes with a set of imaging protocols that are standardized across, implementation-wise, across the vendors, across the scanners, and that everybody can, after some local optimization, just press the button. And you see this in ADNI. This has been done for the ADNI, so the Alzheimer initiative, where there was actually a protocol that has been installed on scanners, and this has really helped in getting much more reproducible data sets. It's still not ideal, but I think, and this, I mean, this would be a huge thing if the vendors would help us with that.
Great, thank you so much. Another question I have here is, can you give any quick advice to the many PhD scientists at the audience who would like to cross the border and reach out to radiologists and physicians and find quick or new ways to collaborate? Any?
Oh, this is a general question.
Yeah, absolutely. Yeah.
Well, I would say if you work in MRI, go to the MRI Together Workshop, because that's exactly what it's aimed at, to connect people. Yeah, to collaborate. So if we're talking about glioma imaging, but this is, I'm sorry, this is a European initiative, but there is Glimmer. So if you look at glimmer.eu, so GLIMR.eu, it's something you can join from everywhere in the world. And it again is a collection, so it's European funded, of anybody who is into MRI research for glioma, whether you're a physicist or a physician or basic scientist. And the good thing that COVID has brought us is that all of this is online. So there's workshops, there's meetings, so you can participate from anywhere. There is also funding, but that is only for, for European-based people at the moment. But of course, yeah, that still is only part of it. And apart from that general advice, yeah, go to workshops, meetings.
Gotcha.
But yes, how?
Great, thanks. And the last question I have here to end with is, you've mentioned those algorithms for either segmentation or for grading, including the CNN algorithm. And I'm wondering if you're using, let's say, tailored or expert-based features or derived by radiomics, or are you plugging in the images as they are and letting the machine learning to figure out the best way to handle the data?
Yeah, these are deep learning algorithms, so we don't pre-select or use selected features based on expert advice or expert knowledge. So we really just plug in the images and see what comes out. Yes.
Got it. Great.
Yeah.
So thank you so much again, and I think we're going to conclude with that. And again, it was a great talk, and we hope to see you next time in person.
Yes, that would be great. Thank you so much.
Great. Goodbye, everyone.